Welcome to this explainer on the essentials of antiretroviral therapy. If you're a medical trainee, you're in the right place. Consider this your clinical guide to one of the greatest success stories in all of modern medicine. Okay, let's dive right in with what is probably the single most revolutionary concept in modern HIV care. This phrase you see here, U equals U, it isn't just a slogan, it's a scientifically proven fact that has completely changed the game for patients and for public health.
So here's how we're going to break it all down. We're going to follow the complete clinical journey. We'll kick things off with that revolutionary idea of treatment as prevention. Then we'll get into prophylaxis, what you do before and after an exposure. From there, we'll walk through the modern diagnosis, talk about starting therapy, and wrap up with the really crucial stuff about long-term care. First up, let's really dig into why that opening quote, undetectable equals untransmittable, is such a huge deal and what it actually means for you and your patients.
So what does U equals U mean in the clinic? It's actually really simple, but it's profound. When a patient is on effective antiretroviral therapy, ART, and their viral load is suppressed so low that we call it undetectable, they cannot sexually transmit the virus to a partner. The risk is effectively zero. This is a life-changing message that helps tear down stigma. It means treating one person is an incredibly powerful way to prevent new infections for everyone.
And this number, wow, this really puts the public health challenge into perspective. The overwhelming majority of new infections aren't coming from people who are on treatment, not at all. They come from the gaps in the system, from people who don't know their status yet, or who, for whatever reason, aren't connected to care. That's why testing and getting people into treatment is so critical.
So if treatment is prevention, what about preventing an infection from happening in the first place? Well, that brings us to the next part of our toolkit, the strategies we use before and after a potential exposure. And you've probably heard of them, PrEP and PEP.
The easiest way to think about this is that PrEP and PEP are two sides of the same prevention coin. PrEP is proactive. It's a medication someone at high risk takes before a potential exposure to stop the virus from ever getting a foothold. PEP is reactive. It's an emergency course of medicine you start after a possible exposure. You absolutely need to know the difference. Now, if someone comes to you after a potential exposure, you gotta remember the clock is ticking. Seriously, you have a 72-hour window to get them started on a 3-drug regimen. Any later than that, and it's probably not going to work. It's a full 28-day course of treatment, and it's crucial that you schedule all the follow-up testing to make sure they remain HIV negative.
So who should you be thinking about for PrEP? Well, this table is basically your cheat sheet from the guidelines. You're not just giving it to everyone. You're looking for individuals with very specific risk factors. Things like having a partner with HIV, not always using condoms, or having a recent STI. It all comes down to having an open, honest conversation with your patient to figure out who would really benefit from this amazing prevention tool.
Okay, let's shift gears now. Let's talk about that pivotal moment when a person receives their diagnosis. This is where your role as a clinician is absolutely central, starting with how you confirm the test and stage the disease.
You know, the first step in this whole process actually happens way before a diagnosis is even on the table. This recommendation for universal screening, it's a huge paradigm shift. We've moved away from only testing people we think are high risk. Now, HIV screening is becoming a routine part of adult healthcare, just like checking your blood pressure. Okay, here's a classic clinical scenario. You're in clinic, you get a lab result back, and the initial HIV test is reactive. What do? What's the very next thing you should be thinking? Your first move isn't to deliver a diagnosis. It's to start the confirmation process. And this right here is your playbook. It's a multi-step algorithm to make sure you get it right. That first reactive test needs to be followed up with a second, different test, one that can differentiate between HIV-1 and HIV-2. And if, for some strange reason, the results are still unclear, a nucleic acid test, or NAT, is the final tiebreaker that gives you a definitive answer. So once that diagnosis is confirmed, this is your initial workup checklist. You need to get the key HIV numbers, the CD4 count, and the viral load. And you also need to check for any pre-existing drug resistance. But you're also getting a full picture of their overall health, baseline kidney and liver function, their metabolic status, and screening for a whole host of common co-infections. This baseline is absolutely essential for choosing the right therapy. All right. Let's move on to arguably the most impactful decision you'll make in this entire journey, starting the therapy that is going to save and completely change your patient's life.
This right here is the modern mantra of HIV medicine. We do not wait. Gone are the days of watching the CD4 count drop before starting treatment. That's ancient history. The evidence is crystal clear. The sooner you start ART, the better the long-term health outcomes, and, of course, the sooner you stop transmission.
So what do we actually start with? Well, for most folks who are just starting out, these are the go-to guideline-recommended regimens. They're built around a class of drugs called integrase inhibitors, which are incredibly effective and have a high barrier to resistance. That's why you see drugs like Biktarvy at the top of the list. It's powerful, it's well-tolerated, and it's just one pill once a day, which is huge for making it easy for patients to stick with. Starting therapy is a massive victory, for sure, but it's not the end of the road. It's really the beginning of a lifelong partnership. The journey now shifts to long-term care, where you'll be monitoring for both success and any potential issues down the line. This is so important to understand. Because our patients are living long, healthy lives, our focus as clinicians has to get bigger. We're not just managing a virus anymore, we're managing a whole person who is aging with a chronic condition, and that means we have to pay really close attention to things like heart health, kidney function, and bone density. So, while getting the viral load to undetectable is goal number 1, that's really only half the battle. You also have to watch the CD4 count come back up. We call this immune reconstitution. Think of it this way. The viral load tells you how well the meds are working, but the CD4 count tells you how healthy the patient's immune system actually is. And if it's low, they're at risk. And this right here is a perfect example of what that risk can look like. This is oral candidiasis, or thrush. It's a classic clinical sign of a weakened immune system. It's something you should always be looking for on your physical exam because it's a clear signal that the immune system is still vulnerable. Okay, this table, you just have to know this. Seriously, burn these numbers into your brain. These are the critical CD4 thresholds for starting prophylaxis to prevent some really dangerous opportunistic infections. Below 200, you have to protect against PJP pneumonia. Below 100, you add coverage for toxo. And below 50, you prevent MAC. Knowing these numbers will save lives. It's as simple as that. Let me give you a really practical clinical pearl you'll run into all the time. Many of the best regimens include a drug called tenofovir, but it comes in 2 main flavors, TDF and TAF. Here's the bottom line. TAF is the newer, updated version, and it's much gentler on the kidneys and bones. So for any patient who has or is at risk for kidney or bone disease, TAF is the clear winner. And we'll end on this thought. We have accomplished something truly incredible in medicine. We've turned what was once a death sentence into a manageable chronic condition. But the work is not done. So what's next? The next frontier is perfecting long-term care, managing the complexities of aging, and of course, continuing the passionate search for a cure. And that's where the next generation of clinicians, all of you, will lead the way.